Good evening, everyone, and welcome to our SPIDER webinar series designed to improve our understanding of providing appropriate health services to people living with intellectual disability. In this session, we're going to focus on the gastrointestinal system, and how this is important when caring for people with an intellectual disability and neurodevelopmental differences. My name is Robert Ward, and I'm a full-time GP down in Geelong. I'm also the father of a young man who has an intellectual disability, and I have the role of the facilitator for this evening's webinar. The SPIDER project is an initiative of the Westmead Primary Health Network aimed at improving the health services available to people with an intellectual disability. And joining us today are Nicole Radford and Kerry Robertson, the project managers for the SPIDER project, and also representatives from the West Victorian Primary Health Network. So I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways on which we're meeting this evening. We recognise their diversity and resilience and the ongoing place that First Nations people hold in our communities. We pay our respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination for First Nation peoples and organisations. Just a little bit of housekeeping at the start of this webinar. So the majority of our webinar events are recorded and are freely available on the PHN Learn Tube channel. And there's links there up on the screen. So we're going to put a link in the chat to all the pre-recorded, all the recorded webinar events that we've done. We have the upcoming events on the screen as well, so you can register for events that are coming up by the SPIDER team. So that link's also going to be in your chat. Please make note that the Westvic PHN Health Pathways relating to topics about intellectual disability is up on your screen now, and that has a lot of really good resources for primary health practitioners to improve the health outcomes of people with intellectual disability. So the West Victorian PHN wants to understand the needs of the communities and what we serve. Every 3 years, they ask the people that live and work in our communities about the health issues they face and what services they need to be addressed. The Western Victorian PHN wants to know what health issues are most important to you and your community, and your ideas for addressing these health issues and what services are required. You can fill out the short survey and use the map to tell them about your health and the services you need, or tell a story that demonstrates the need. You can also request a phone call or a meeting with you or your practice to share your thoughts. So head to the project page and share your thoughts, sign up for updates, or request a meeting. Materials can be provided to you to promote engagement with your patients and colleagues. Now, if you've entered this webinar not displaying your accurate first and last name, please type them in to the chat box. Only the administrators will be able to see this, and this will just ensure that you get the appropriate certificate of attendance. So for this evening's webinar, all the participants will remain on mute, and you can have questions. And if you have questions, just type them into the Q&A box, and I'll ask them on your behalf when we have our question time, which will be after the presentation. There is a link in the chat box to complete a survey after the webinar, and we'll show this slide again at the end of the presentation. So the session today is focused on the gastrointestinal system, in particular, the relation to people with neurodiversity and intellectual disability. And we're very lucky to be joined by Dr. Ted O'Loughlin, who's a paediatric gastroenterologist from the Sydney Gastroenterology Group. Ted is a highly experienced gastroenterologist with a special interest in the gastrointestinal and nutritional disorders of children with developmental disorders. And he's also heavily engaged with teaching junior doctors the specialty. We were also hoping to be joined by Judy Wells, who's a stomal therapist and a continence consultant at the Royal Children's Hospital in Melbourne. So hopefully Judy will be able to join us as well for a discussion on this important subject. So we've all learned through the SPIDER project that diet and good nutrition are important for the well-being of people with intellectual disability, but there are often many challenges in this area. Bowel dysfunction can be a major additional factor complicating care and adding to disability. Dysphagia is an important condition that may often be missed and have significant health consequences. Then The gastrointestinal tract may be a hidden cause of behaviours of concern. It may be related to the medications that we've prescribed, and it may even lead to increased medication burden, dietary restriction, or impaired community engagement. And it may be poorly understood by those charged with caring and supporting those with an intellectual disability, including their general practitioner. So I'm really looking forward to hearing Ted and Judy's insight today on this important aspect of care for our patients with an intellectual disability. And I'd like to hand over to you, Ted.
Thank you very much for the introduction. So I'm a paediatric gastroenterologist at the Children's Hospital at Westmead, and I sort of fell into this area a little bit by accident. I'd just like to give you a bit of historical background of how I and some of my colleagues got involved in this area. Back in the 90s, people with intellectual and physical disability in New South Wales were under the care of a government department called Ageing, Disability and Home Care. And a lot of people lived in residential care, and there were lots of therapists in community health centres looking after patients. And someone realised, or a bunch of people realised, that dysphagia was a significant problem in people at the severe end of the physical disability spectrum. So there I'm talking about the GMFCS5, or people with conditions such as cerebral palsy. And so Ageing, Disability and Home Care started doing a dysphagia survey. They figured out a survey and then started going through the people under their care, running a survey. And they're picking up a lot of people with significant dysphagia, but they had nowhere to send them. So there weren't any multidisciplinary clinics in New South Wales to deal from a medical perspective. And so a colleague, Helen Somerville, who was a developmental doctor, and I got together and decided to set up a clinic at Westmead Children's Hospital. And she also set up a similar clinic at Westmead Adult Hospital. And to date, these are the only two multidisciplinary clinics that are running to investigate and try and help in this area in people with largely physical disability. So we're talking largely about people with pseudobulbar palsy and other neurological causes of dysphagia. So we call the clinic the Dysphagia Clinic. And a lot of what I'm going to talk about is really anecdotal experience. And in the course of all this, I realised that people with severe physical disability, developmental disability, are really the orphans of the medical world. And on one occasion, I decided to try and find out how many randomised controlled trials were done in this group of patients. And I could only find stuff on Botox injections for musculoskeletal contractures. So they really are a group that's sort of been left out on the edges. So what I want to talk about is the sort of things we did and why we did them, and some of the data we collected, around the 2000 to 2010. So these were the members of the original clinic. Helen Somerville, developmental paediatrician, myself, and then we had a couple of nurses come through, a dietitian, a couple of speech pathologists and a physio. Plus we used to get a fair bit of information from community health workers, school teachers, etc. And so let me just go back. This just shows the neurologic innervation of the gastrointestinal tract. And I guess the moral of this story is the gut is very closely connected to the brain. And, these networks are also becoming very clear in conditions like inflammatory bowel disease and irritable bowel syndrome. But in developmental disability, stroke, neurological injury, if you injure the central nervous system, it's going to have a lot of downstream effects, particularly in the gastrointestinal tract. Parasympathetic nerve supply comes out at the top end through the vagus, and that supplies the gut, both sensory and motor, all the way through to the right colon, and then the sacral nerves, parasympathetic nerves supply the distal bit of the colon rectum. These are important connections because, as I say, if you injure the brain, then you're likely to have a problem with coordination downstream. But also, many of the conditions that we deal with in paediatrics aren't brain injury per se. They're more developmental problems. So they might be disorders of neural migration or nerve development, syndromes that involve neural defects. So as a general rule, if you've got some genetic problem affecting your central nervous system, it's also going to affect, it may also affect the enteric nervous system, which is the largest collection of nerves outside the central nervous system, including the spine. So many of the disorders, developmental disorders in childhood, and that group that actually survived adult life, they do have significant problems with the enteric nervous system and hence control of gastrointestinal function. So this is this is from a paper in 2008. Ellen Somerville and I and others did a review of it would have been about 8 or 9 years of our clinic at that stage. As I said, there was a clinic at the Children's Hospital at Westmead. We had almost 300 patients at that stage. And Helen had set up the adult clinic at Westmead. She had fewer patients because many of our clientele didn't actually survive long enough to get into her clinic. So the majority of the clinical diagnoses were cerebral palsy. There are a bunch of genetic syndromes like Down syndrome. There's a whole host of them. If you're interested in the syndromes, you could look up Smith's patterns of human development. There's hundreds of them listed in there. There are chromosomal abnormalities such as Down syndrome, a group of neurodegenerative diseases. We had a handful of children who had cerebral palsy-like phenotypes where there was more than one person in the family. So they clearly had some inherited problem, but it hadn't been diagnosed at that stage. There are a small group of patients with congenital infections. And in the paediatric group, it was congenital CMV because by this stage, most of the kids had been vaccinated against rubella, or their mothers had been vaccinated. And also in adults, there were some kids, bigger kids than adults with congenital rubella. There are a few kids with autism, and they were more eating disorders rather than dysphagia. And there's a whole bunch of undiagnosed medical conditions. The diagnostic rate is much better now because of the more sophisticated genetic techniques that are available. So many of the patients coming through now have a specific diagnosis. And many of the conditions are genetic, even though they look like maybe cerebral palsy, they are genetic disorders. So we call it a dysphagia clinic because that's what we set up to do. So of the kids, the majority had dysphagia, and slightly smaller percentage of the adults. If you can't eat properly, then one of the side effects of poor nutrition, you don't eat enough calories, you're going to get skinny and you're not going to grow properly. And so 2/3 of our patients were undernourished or had well-defined malnutrition. Because of the brain-gut connection, as I said, if you injure the brain or it doesn't develop properly, then upper gastrointestinal function is significantly disturbed. So reflux is a common problem in this group. So if you have reflux and you've got pseudobulbar palsy, that really sets you up for aspiration. And of course, there's some of these kids can't even control their normal secretion, so they can aspirate saliva as well. And significant proportion develop esophageal lung disease. And in people with severe physical disability, that's a common mode of death when they get into adult life. small percentage of patients presented with hematemesis, not unreasonable given the high number of patients that had symptomatic reflux. So we try to deal with a number of these management issues. You can't fix pseudobulbar palsy, so you have to sort of work around it and deal with the issues that may arise as a result of that. So one of our main focuses was on nutrition. Given that a significant proportion of patients have reflux and reflux disease, that's fairly easy to treat, so we were aggressive about investigating that. Recurrent aspiration, chronic lung disease are more difficult to treat, but one can ameliorate this, and I'll talk about that a bit further. Because of the nutrition and the upper motor neuron. Because of the neurological wasting and the malnutrition, bone health was a consideration. And a significant proportion, about 30 or 40% of these patients suffered from epilepsy. And it can be quite an intractable problem in this group. And many of them are on multiple anticonvulsants. And that was one of the things I was interested, I alluded to earlier. And when I last checked, there were no randomized controlled trials of anticonvulsants in this particular group of patients. So it was all very empirical treatment from that point of view, but we didn't, neither Helen nor I engaged in the management of their epilepsy. That was done by neurologists. That was well above my pay grade, I'm afraid. So as part of the workup of the dysphagia, we had a speech pathologist who were experienced in doing modified barium swallows. So that's where you do. We don't call them barium anymore because you can't get barium. I don't know whether people in Victoria have noticed, but we have to use water-soluble contrast now because there's a world shortage of barium. So they're called contrast swallows, not barium swallows. Being a bit of a dinosaur, I refer to them as barium swallows. So we had speech pathologists who were experienced at doing modified barium swallows. So that's where you get the individuals of interest to swallow contrast mixed in with foods of varying consistency, all the way from thin liquids all the way through to thick purees, to try and get a handle on coordination of swallowing. And from my perspective, I was mostly interested in whether patients aspirated. I wasn't sure how accurate the interpretation of palatal movement and swallowing was, because I knew from the history that they had poorly coordinated swallowing, because I mostly had dysphagia. And what Helen and I were interested in was the problem of aspiration. And one of the issues with aspiration is there's no gold standard test for aspiration. So people do contrast swallows, nuclear medicine swallows, milk scans, esophageal pH metry, but there's no gold standard. So one can't work out the sensitivity and specificity of the various modalities we use. So we primarily went on the history. If they had respiratory symptoms and a poorly coordinated swallow, then there was a high likelihood that there was aspiration of some type, whether it was saliva or swallowed food or reflux and aspiration. We often made clinical decisions about that, and we use the contrast studies as a way of helping to consolidate the diagnosis. But if they didn't aspirate, if they had poorly coordinated swallow and didn't aspirate on that particular study, it didn't mean that they weren't aspirating. So we often gave them the benefit of the doubt and treated it anyway. I'll get back to the imaging. So the other problem that was very substantial was malnutrition. 2/3 of the patients were under or malnourished, and so we decided to look at the question of malnutrition and the benefits of nutritional rehabilitation. And as it happened, there was a guy in my department at the Children's Hospital called Kevin Gaskin, who was a paediatric gastroenterologist, and he was also a professor of nutrition. And he set up some pretty sophisticated techniques for studying body composition, including body protein measurement. We could measure bone mineral content with DEXAs. We couldn't measure body water, but we could measure everything else, body fat. And so we decided to study the subgroup of patients. And because it was such a heterogeneous clinic, we decided to focus on patients with cerebral palsy. And because it used to, when I was a young trainee, the seniors used to say, if you force feed kids with cerebral palsy, all you do is turn them into butterballs, and it was a bit of a waste of time. So we decided to look at that because in most other areas of medicine, nutritional rehabilitation does have benefits in terms of intercurrent infection and survival. So we decided to take a look at this, and we had a dietitian, Fiona Arrowsmith, who did a PhD in this area. And because Kevin had set up his techniques primarily to study cystic fibrosis and other conditions such as metabolic diseases, we were able to generate a lot of control data. So this slide basically shows anthropometry in almost 60 patients with cerebral palsy, and these are severe spastic quadriplegic cerebral palsy patients. And we had 172 controls. And so the simple anthropometry, the age was slightly different, but we were able to normalise that using standard deviation scores rather than absolute numbers. So when we looked at the spastic quadriplegic cerebral palsy group, their weight for age standard deviation score was almost 5 standard deviations below the mean. Their height for age was 3 standard deviations below. Their upper arm circumference was also well down, and we were able to measure their total body fat in kilograms from skin fold measurements, and there was a very substantial difference between the kids with cerebral palsy and our age-matched controls. But interestingly, when we looked at our ideal weight for height, it was normal. So basically what this information is telling us is the patients are malnourished and they're also stunted, bearing in mind that it's very difficult to get an accurate height measurement in cerebral palsy and some of these other neurological conditions because of patients often develop scoliosis and they have joint contractions as part of their neurological problems. So we had to use a few funny tricks to try and estimate their height, and you can get a rough idea by measuring lower limb measurements. So the length of the fibula and tibia, and then you can read off standardised charts to determine the height. So that's how we work out the height. So there was a significant problem with malnutrition. So this slide shows body fat measurements, and we can see 2 lines. The open circles are the controls, and the solid circles are the kids with cerebral palsy. And you can see this is a cross-sectional study showing what happens at different ages, and you can clearly see as they get older, they drift further and further away from the normal range. So that's body fat. So this is body protein. Again, we're seeing the same thing. So the body fat decrease is clearly due to inadequate caloric intake because most of these patients did not have malabsorption. The body protein was a little bit more dramatic. The patients were, by the time they got to the end of adolescence, they were well below the normal range. But the problem with measuring body protein is that you have two components. One is your nutritional status and the other is neurological wasting. So certainly in cerebral palsy, there is a lot of upper motor neuron problems and muscle wasting from that. And so we were interested in trying to tease out how much is due to malnutrition, because that's the bit you can fix, versus how much is from neurological wasting, immobility, lack of exercise. So that's body protein. I won't go into the details of how we measured that, but we had the help of the Australian Nuclear Science and Technology Organisation to measure using fancy physics to measure body protein. And the next one shows bone total body calcium. So this is bone mineralisation, and you can see that's as dramatic, if not more, as the body protein. So the open circle are the controls, and you can see the incredible increase in calcification of their bones as they go through puberty, and the kids with the cerebral palsy are substantially lower. So they do have a significant problem with bone density, and as a result, there is an increased risk of fractures in this group. So the other question was, people used to say that people with cerebral palsy and neurological conditions like that are skinny because they have increased energy expenditure. You know, they often have dystonia and movement problems and they expend more energy. So what we did in this is we measured resting energy expenditure, and we then measured total resting energy expenditure and then divided it by the kilograms of protein. So we're able to get resting energy expenditure per kilogram of protein. And you can see again, the open circles are well below our normal controls, the open circles. So basically so there's no reason why a muscle in someone with cerebral palsy should have less resting. You can understand active energy consumption when you're moving, but resting energy consumption should be the same. So our interpretation of this was that this is an adaptation to chronic malnutrition. So when you're chronically calorically starved, you drop your energy metabolism to try and conserve tissue. And that's a response to chronic malnutrition. So our interpretation here was that these patients suffering chronic malnutrition were slowly adapting and reducing their resting energy expenditure to try and conserve body tissue. So in this particular slide, we measured resting energy expenditure using indirect calorimetry. And because females and males have slightly higher resting energy expenditure, that's because of hormonal factors. And so we divided the groups up into females and males. And this was by way of follow-up of the observation that our unit protein or unit protein energy, basal energy metabolism was reduced due to chronic malnutrition. And you can see that the measurement of the resting energy expenditure confirms that impression. So this is done early in the morning. The patients are lying still on the table, so they're at rest, and then their energy expenditure is measured under those conditions. And you can see in the females, their resting energy expenditure is about half. This is measured in kilojoules per 24 hours. That's about half of that of normal controls, and similarly with the males. So in fact, these patients do not have higher energy consumption than normal. They have lower energy expenditure, and some of that is due to adaptation to chronic malnutrition. What one could imply from this that it should be fairly straightforward to nutritionally rehabilitate these patients and fix their malnutrition, and then their measures would end up similar to the control patients. The other thing that it implies is because they have lower resting energy consumption, and their anthropometry demonstrated that they have significant malnutrition, the problem must be secondary to intake rather than their metabolism. So this implies that they've got a major intake problem. And of course, if you've got dysphagia, that's highly likely that's going to be the case, unless you can bypass the swallowing. So we decided to look at this, and the dietitian did 5-day food records and measured the various nutrients. So here we're depicting energy and protein. So this is a 5-day weight record, measurement of energy and protein. So we've got a bunch of kids who are orally fed, and then a subgroup that are tube fed. So, sorry, the combined group was then split to tube and orally fed. And remember, this is by way of report. We know these patients are malnourished and they've got reduced energy expenditure. But by report, the parents were saying, well, they were eating an enormous amount of food because their energy intake was 246%, the combined group, 246% of recommended dietary intake. And if you look at the orally fed group, it's almost 3 times more. So how does that match up when you have reduced energy metabolism and you've got malnutrition and you're eating 2 or 3 times what's normally prescribed for children of that age? And protein showed a similar trend. So our interpretation of this is that food intake was grossly over-reported by the parents. And when you watch kids being fed, I mean, often the kids at the severe end of the spectrum, they would have a plastic bib on with a bit of a gutter at the bottom, like you use for babies, and the parents would be feeding them, or the carers would be feeding them, and a spoonful would go in the mouth, and the majority of it would end up in the bottom of the bib. And so the conclusion was that the description of the food intake by the carers, by the parents, was grossly exaggerated, and it indicated to us that there may be a problem with the parental perception of how things were going versus how we, the medical providers, were perceiving as how things were going. So we concluded from that particular study that patients with the cerebral palsy and cerebral palsy type phenotype at the severe end of the disability spectrum were frequently wasted, stunted, fat depleted. Mineralisation of their bones was very problematic. Their energy metabolism was actually decreased rather than increased. And there were issues with parental reporting and the parents' investment in the whole process of feeding, bearing in mind that many of these children had severe dysphagia, quite a percentage had aspiration, chronic lung disease, reflux disease, aspiration of saliva. But parents are often very committed to the social aspects of feeding, even though it was causing a problem with the children's medical situation. So more of that later. So reflux disease is a common problem, again, because of the brain-gut connection. If you injure the brain or disrupt the nerve connections from the brain to the gut, you do get upper gastrointestinal dysmotility, and reflux is a common complication because of problems with gastric emptying and control of the lower esophageal sphincter. And of course, reflux is a major problem in someone who's got severe swallowing incoordination dysphagia. So children who had symptoms of gastroesophageal reflux, whether it was frequent regurgitation, vomiting, crying, pain sort of behaviour, the best way to work out whether there's disease is to do an endoscopy. And so that's what we did, looking for esophagitis. I think you need more in this group than just proving that they've got reflux, because everyone refluxes, but it's a matter of degree. But what you can do something about is reflux disease. So reflux esophagitis is relatively easy to treat. Proton pump inhibitors are the go-to medication in the gastro world for this. So that's pretty straightforward. If you've got esophagitis, you can treat with PPI and fix the esophagitis. So it's very effective treatment. So we didn't always rely on the endoscopic appearance. This does show inflammation in the esophagus. Picture's a bit blurred, but you can see these streaky lines running down the esophagus, lower esophageal sphincter down there. But sometimes the endoscope lies, so it's always useful to have biopsies. And in fact, this particular biopsy is of the esophagus. And you can see these pink cells in the esophageal mucosa, they're eosinophils. So in fact, this patient actually had eosinophilic esophagitis, not reflux esophagitis. So that's chronic eosinophilic esophagitis, which is a disease that's popped out since the mid-1990s and goes hand in hand with asthma and eczema. So, but reflux esophagitis is much more common in people with severe disability, physical disability, and certainly in our group of patients, it was more common than eosinophilic esophagitis, as I'll show you. We talked about contrast swallows. The sensitivity and specificity of a contrast swallow and meal to diagnose reflux is about 50-50, so you may as well rely on flipping a coin. It is a very useful test if you're worried about anatomical problems in the esophagus or upper gastrointestinal tract. For instance, if you're worried about volvulus, malrotation of volvulus, if you're worried about extrinsic compression of the esophagus, for example, a vascular ring, which is not unheard of in some of these genetic syndromes, esophageal webs and things like that. Excellent test. The diagnosing reflux, we don't go there. You can quantitate reflux using impedance, esophageal impedance studies. We used to call them esophageal pH metry. Now they're called impedance. The problem is that impedance studies do quantitate the amount of reflux you have, and there's criteria for what's pathological, but pH studies don't predict disease. They don't tell you if you've got esophagitis. They don't tell you whether you're aspirating. So we were more likely to rely on the history and the more simple investigations such as endoscopy and biopsy. So we organised upper endoscopy in a lot of patients, and as you can see, of 182 kids who we were suspicious, 81 of 182 had reflux esophagitis. 14 had Barrett's esophagus. That's where you get columnar epithelium migrating up the esophagus. It's a response to chronic acid injury of the esophagus. And in long-standing Barrett's esophagus is precancerous. And there are reports of children as young as 18 with cerebral palsy developing carcinoma of the esophagus. I've never seen it, but it is reported. So esophagitis, as I said, is easy to treat. Percentage of patients had Helicobacter pylori, 22 out of 182. I mean, you know, we pick up a hand, out of 1,000 endoscopies, we probably pick up 10 or 15 kids with H. pylori in a normal endoscopy list. However, there is data indicating that developmentally delayed or neurologically impaired children with gastrostomy tubes who spend time in residential care, have a higher risk of Helicobacter pylori because it can be transferred hand to gastrostomy. So in institutions, there's a higher risk of Helicobacter pylori. What about the lungs? Well, about 2/3 of the patients had chronic respiratory symptoms. So we defined that as having more than one respiratory infection requiring antibiotics, particularly in the winter. And in the early days, when we were dealing with patients with severe oropharyngeal dysphagia and gastroesophageal reflux disease who had respiratory symptoms, we were interested in fixing the reflux. Now, at the moment, there's only one fix for reflux, and that's a Nissen fundoplication. The medications that are used do not fix reflux. PPIs fix the esophagitis. Prokinetic drugs haven't been all that effective in controlling reflux. Thickened feeds reduces the amount of regurgitation or vomiting to the mouth, but doesn't stop you refluxing. So if you've got chronic aspiration, suppurative lung disease, and you want to fix the reflux to get that out off the table, then you need a surgical fix. And in the early days when we were doing this, the surgeons were really reluctant. Disability is a real bogeyman in anti-reflux surgery. So many units won't do it. Fortunately, we had outstanding surgeons in our unit. One guy was a liver transplant surgeon who was absolutely brilliant. Sadly, he's only just retired. So we had excellent outcomes from our fundoplications, and we subsequently reported that. I didn't have time to discuss that today. So initially we did a lot of CT, and this CT shows patient with cerebral palsy, has scoliosis, and has evidence of bronchiectasis, and also atelectasis. You can see the so-called signet ring appearance of these smaller bronchi. And these coronal sections of bronchi is showing quite thickened and inflamed bronchi. So this patient has aspiration and chronic suppurative lung disease. It does cause a lot of morbidity. Children get pneumonia on a regular basis from suppurative lung disease. They end up in hospital, end up on antibiotics. And we figured if we could stop the aspiration, we may be able to improve their quality of life. So eventually we convinced the surgeons and could stop doing CT scans. So did a lot of children, 62 kids. I mean, they're selected, of course, they're children that had symptoms, plus or minus finger clubbing, which in that group of patients definitely indicate suppurative lung disease. So 2/3 of them had evidence of bronchiectasis and the rest had inflammatory changes. Smaller number of adults being investigated. That's because a lot of the children we looked after with bronchiectasis didn't survive long enough to get into the adult clinic, but they died from their chest disease, usually, or from seizures. So chronic suppurative lung disease is relatively common in this group of patients and potentially preventable. So because people thought that nutritional rehabilitation was a bit of a waste of time in this group, we decided to have a look at it. We had a dietitian and species involved. We'd assess the diet and try and increase the calories. So largely by increasing the fat content in the diet, because there's 3 times more calories in fat almost as there are in carbohydrate and protein. We had a speech pathologist who would assess the swallowing, and we'd try and improve things there by increasing the consistency of food. We have a physiotherapist who would help in terms of design of wheelchairs and positioning of the patients so that they were in safe feeding position. And if those things didn't work, then we got more aggressive, putting in gastrostomy tubes, etc. So we did a lot of interventions in this group. We recommended a lot. And again, this comes back to the sort of the medical perceptions versus the parental perception. So we recommended gastrostomy insertion in 140 kids. That was to improve nutritional intake and or to deal with reflux and possible aspiration. And so of the 140 where it was strongly recommended, only 91 agreed. Similar thing happened in the adult population. Many were called and fewer were chosen. Similar pattern, we recommended fundoplication in 111 and actually performed it in 74 of this clinic. And that group of patients has subsequently been reported, and there were excellent long-term outcomes from the fundoplication. So they were the interventions. So if you can't swallow and you're malnourished and you're at risk from aspiration, one way of dealing with it is stop food going in the top end and putting it directly into the stomach. And you can ensure adequate nutritional intake. If there is a problem with reflux and reflux disease, then you can deal with that with a fundoplication. So gastrostomy and fundoplication was frequently recommended together. So what about the lower gastrointestinal tract? Again, just this picture is from Gray's Anatomy. What I tried to learn anatomy from when I was a medical student, and that's why I don't know much anatomy. But I do remember this because it comes up in all aspects of my gastroenterology practice. Again, the neural innervation of the gut, you've got the vagus nerve from the top, you've got the sacral parasympathetics from the bottom, and the sympathetic supply that goes in largely controls blood supply to the gut. So motor function, secretion, bowel action, all that sort of stuff is controlled by the parasympathetic. So once again, if you scramble the central nervous system, you're going to have downstream effects. If you damage the spine, similarly, if you've got a genetic disorder that has a major impact on neuronal development, migration, etc., it's also likely to affect the enteric nervous system. So constipation, to a large extent, it's due to the neurological issues, to immobility, and probably to a lesser extent to dietary intake and water intake. So, I mean, heaps of people say, you know, if you drink more water, you'll fix the problems of constipation. That's a bit of an old wives' tale. That's true if you're walking across the Simpson Desert. If you don't have enough water, you're going to get constipated because you get dehydrated. But if your hydration's normal, increasing your water intake, unless it's mixed with Movicol, is not going to make any difference. Water gets absorbed in the upper gastrointestinal tract and it ends up in the toilet bowl usually. So it doesn't usually get down to the colon. So dietary intake is important. Immobility is very common, and we see it in the normal population. The kids who are quite sedentary are often the ones that turn up with tummy pain and constipation, because exercise does seem to have an effect on your bowel function. So what about treatment? Well, you can put it in the top end. So basically the ones in yellow are our go-to medication. So lactulose is a fermentable sugar that gets fermented in the large bowel. The fermentation products are small chain fatty acids that draw water into the bowel, but also can produce excess flatulence. So in patients who seem to have a lot of pain behaviour, or normal people with irritable bowel syndrome, lactulose and sorbitol can actually aggravate the symptoms of pain because of gaseous distension, but they are very effective in treating the problem of constipation. And also they're quite sweet, so it's easy to get kids to drink these things. If you've got a gastrostomy tube inside you, it doesn't matter whether they want to drink it or not. It's easy enough to put it down the gastrostomy. Movicol is like a colonic lavage type solution. It's a mixture of salt and macroagrol. So the salt is in there to balance the salt content of the intestinal lumen so that you don't cause problems with hyponatremia or hypokalemia. And the macroagrol just draws water, or retains the water in the lumen of the bowel. So it stops it getting absorbed effectively. So basically, Movicol just acts like a flush. And sometimes you need a bit of a stimulant, because they often, children and adults in this group have sluggish gut, sluggish peristalsis, poor muscular contractility and coordination. And so a stimulant is often helpful. If you get really bunged up, then go to something that adult gastroenterologists would use for prepare someone for a colonoscopy. So Picolax, Picaprep, that sort of stuff. Dietitians will also add fibre and psyllium husk into the feeds if they can be a problem getting it through a gastrostomy button, though, because it can block up the valve in the button. So it may be problematic getting it in if the patients aren't swallowing. You can also go for the rear end. Tap water, soap, and phosphate are definitely no-nos because they can cause major electrolyte disturbances. Phosphate enemas have been known to cause severe hyperphosphatemia and renal failure. So glycerin suppositories, enemas, because they will stimulate a gastrocolic reflex. A rectoanal inhibitory reflex. So if you distend the rectum, you'll stimulate peristalsis, and it can stimulate relaxation of the anal sphincter. So enemas are a good go-to if the patients are impacted. So saline enemas would be the way to go there. Glycerin suppositories, some Coloxol. If all else fails, then the options are using colonic lavage type preparations to flush kids out intermittently or patients. Sometimes there are major gastrointestinal motility problems. Some of the syndromes do have degenerative problems in the enteric nervous system. And so patients can develop a pseudo obstruction type picture. In fact, we have a handful of kids who've ended up on home TBN because of the significant gastrointestinal motility problems associated with some of these conditions, such as cerebral palsy, mitochondrial diseases, some of the syndromes. And here I'm thinking of Rett syndrome as a classic, where there's a gradual deterioration of the enteric nervous system. So one may need to get more aggressive, and by that I mean appendicicostomies and cecal buttons to allow lavage directly into the colon. So sometimes you've got to go that far. Very occasionally you may have to resect a bit of colon to try and reduce. If the major motility problem has been isolated to the large bowel, then one can remove segments to reduce the amount of disrupted colonic motility. I've only ever had to resort to that once. Now we talked about, I'm sorry that this slide hasn't, I don't know what's happened here. The main bits aren't being shown up. Oh, here we go. They are now. So I've alluded to the fact that often there's a discrepancy between the expectations of the service delivery people, the medicos, the allied health people, and what the parents want. And so one of our colleagues, Angie Morrow, who's a rehab physician at Westmead Children's Hospital now, did a PhD in this area, and she did some focus group surveys of staff looking after the patients and also families to see how their ideas married up in terms of service delivery. So these were the major themes: parent-child interaction, physical well-being of the child, emotional well-being, and socialisation. So she did a PhD around this area. I'll just show you some of the results. So this is a comparison of the major themes: delivery of services, parent-child interaction, physical well-being, emotional well-being, and socialisation. And the blue are the health professionals. That included medicos, social workers, dietitians, etc. And the cerise are the patients. And you can see that there's quite a discrepancy in their idea of how good the delivery of services were. Of course, medicos are always going to think the delivery of services is excellent. That's not always shared by our patients. Parent-child interaction, medical staff were more negative about that than the parents. Sorry, the parents were more negative about that than the medicos, sorry. And maybe that gave some insight into why there was this problem sometimes when you're suggesting interventions and families didn't want to take your advice, which they're well entitled to, but sometimes you're getting into very significant health issues that could have been ameliorated. Physical well-being, it wasn't too discrepant. But on the other side, the medical staff perceived the emotional well-being of the kids to be a lot less than what their parents viewed it as, and also that we had a very dim view of kids' socialisation, because a lot of these children were wheelchair bound, being in the severe end of the disability spectrum, and there was quite a discrepancy between what we thought about things and what families thought about things. So it does highlight that sometimes health delivery personnel and families aren't on the same page when it comes to the health and welfare of the children. So what about all that? Well, because of the brain-gut connection, GI problems are very common in people with neurological impairment, developmental disability, genetic syndromes that involve problems with brain development. Patients and families are complicated and have unique problems, and sometimes bespoke solutions are required. If you can't get in a gastrostomy, you've got to think of other ways of trying to improve nutrition, etc., etc. Significant, simple interventions, like adequate treatment of reflux esophagitis, or stopping aspiration, can significantly improve the quality of life for not only the kids but also for their families. So, if parents are continually taking their children to medical services, getting them admitted to hospital, because of ongoing acute problems, then if you can ameliorate that, then it's a worthwhile exercise, even if what you do doesn't prolong the life of the patient. In this group of patients, family attitudes to intervention can be challenging. And I give an example here, because I have looked after kids with cystic fibrosis, and they get severely malnourished as well. They often have eating disorders. They have chronic malabsorption due to pancreatic insufficiency. They have chronic suppurative lung disease, and that can affect their intake. And if you approach families about gastrostomy tube insertion in that group, you'll almost never get a no. They usually come on board and they're with you. And so it struck me as being quite unusual in this group. And we haven't teased out why, but I wonder whether it's the whole guilt trip, the whole guilt problem of having a child with a major chromosomal abnormality or significant developmental problem. But it certainly is a challenging thing to deal with in some situations when you feel that the intervention that you're suggesting is really important to try and stop whatever's happening, such as aspiration. So that's all, folks.
Thanks, Ted. It's a really important subject, isn't it? And you touched on a few really important issues there with people who are quite vulnerable in our community and have complex needs. I was just wondering, if Judy, are you able to unmute? Did you have any comments to make? Judy's a Stomal nurse from the Royal Children's. She's part of our panel.
Can you hear?
Hi, Judy.
Hi, can you hear me?
Hello.
I just wonder if Ted's talk had sort of stimulated you for any thoughts that you might have for how you help people with a disability.
Oh, I really, it was great to listen to. I learned a bit, and there was a lot of similar themes working here. I've usually worked down the other end with the constipation more so than with the gastrostomies, but yeah, I guess we also have quite a lot of kids who have appendicostomies, chafe buttons, etc. So we do see that group of kids. But just, yeah, common problems. Some of those stats were interesting. I just have a question. Maybe we do use a large volume bowel washouts with water. And I noticed Ted said no to using water.
Well, saline, we would use saline, but you can get water dilution because the colon's very efficient in absorbing water. So,
Yeah.
you've got to be careful. So we'd use saline if we want to do a washout like that. But we'd prefer to put it down the top end, because effectively enemas will only get you to the splenic flexure. So, our preference would be go down the top end. A bit like dealing with kids with meconium ileus equivalent with cystic fibrosis.
Yeah. Yeah.
But look, if it works, whatever works.
Yeah.
Worth having in the armamentarium. Just as long as
I guess,
and it's not causing problems.
I guess the kids with the spina bifida group with they're the ones who use a lot, who often have appendicostomies, or they do the large volume washouts when all else has failed. So yeah.
Well, of course, that's the spinal cord's contribution to
so that's a bit different.
Regulating the large bowel. So if you've got a spinal cord problem, then you're going to have a major problem with your bowel habits.
We also have some of the kids going into urinary retention from severe constipation. I wonder if you could comment on that or.
It rarely seems to be a problem in our group of patients, unless they have. I mean, we do have children who develop chronic intestinal sheath obstruction because of neurological degeneration, or muscle, smooth muscle problems, and of course some of those ones do have problems with their urinary retention.
Okay.
But in the cerebral palsy group, it doesn't seem to be a major problem.
Yeah, we just have had a few kids, not a major problem, but some of the kids who can't manage the constipation side of things sometimes end up, and then we have to teach them to do catheters, which is very invasive and very difficult.
And kids don't like it when you're interfering with their undercarriage. No. They really don't like it.
But it's not frequent, but occasional.
Ed, I was wondering if I could ask a question. Throughout these series of seminars, we've talked about doing annual health assessments on people with intellectual disability, and one of the questions is about dysphagia and potential aspiration, because it often be missed in the person with an intellectual disability. And in general practice, we can be looking after that person. It can be a bit of a hidden problem. What would be the things we should look out for clinically to give us a hint that this person may be having trouble with that when they haven't had an investigation, they haven't seen a speechy in the past?
Well, coughing and gagging when they're swallowing. Complaints of retrosternal pain, that might indicate mucosal inflammation, esophagitis. Poor intake. Sometimes they just avoid eating because they know it's. This is what happens in the cerebral palsy population. They really develop aversive eating behaviour because they're so uncomfortable when they swallow. And so the caloric intake goes down and they get malnourished. So depending on what's causing it, if it's pseudobulbar palsy or an esophageal motor problems will often cause discomfort during swallowing. One of the symptoms is patients will take small mouthfuls and they'll often drink a lot of water to wash the food down because it's getting stuck. So they can drink a lot of water. Sometimes they have a lot of regurgitation. So patients with achalasia, the esophagus fills up with fluid, and then they'll start vomiting and regurgitating, and they may aspirate at night. So it depends on what the issue is in the upper gut, but will to some extent determine the type of symptoms. But if you'd need more than just intellectual disability. I mean, pseudobulbar palsy, which is largely what we deal with, goes with other neurological problems. And it could be muscle problems as well, because it's a common presentation of some of the adult neurological disorders as well.
And I suppose when we're looking after with intellectual disability, they may not be able to tell us their symptoms. So
but often their
caregivers
their
behaviours, and
it's really useful to get histories from the caregivers,
people
who are looking after them in their residential care or their parents. They'll have often, because they're often there helping with their food preparation and eating, and they're good observers, so you can get a good history from the caregiver.
Yeah. I also like your comments. Like there was an interesting observation about the difference between the perception from the medical profession necessarily, and the parents and the family and things like that. And I suppose it's really important for us all to involve the families. And I know we should be probably doing that more and more as decision makers in the care we give into the future. And I know certainly one of the things through these seminars I've certainly learned is to listen to the people, listen to the patients, and listen to those caregivers about what they want as an important intervention as well.
Yeah, and sort of that area was a bit of a surprise to us, because it wasn't like the sort of things we were trying to fix were minor health problems. I mean, if you've got suppurative lung disease, that's a major life-threatening situation, and we would suggest stuff, and families didn't want to do, or we didn't force them, but of course you need their consent. We would discuss it and try and sort of ease them into it, but that we found that a little bit surprising, because it's different to a lot of other groups of patients that I deal with. Where people will usually go with you when you suggest stuff. If there's a significant health problem that you're trying to deal with. So yeah, that's a group of families that are a little bit different to the regular group of families of kids with chronic diseases, at least in my experience.
And it certainly must be quite a complex and confronting situation for them to find themselves in. All right, look, we are getting to the end of our time. I don't think there's any questions through the chat. Is there any other sort of final comments that you, Kerry or Ted, would like to make before we end the session?
Well, I'll start. I'm sorry I talk so much. Sometimes I can't shut up. Originally, I thought I was only going to go for half an hour, but but look, this is a challenging group of patients that we deal with. Disability is not considered any bar to even the most invasive sort of treatments. For example, we've done liver transplants on children with severe disability. They're just as entitled to, gilt-edged medical treatment as anyone else, if it's going to help. And so often, in people who don't have a lot of experience in the area of disability, often they're dismissed as, they're too far gone, or they're too sick and it's not worth it. What are we doing here? We won't do that. But disability is not a contraindication to standard medical treatment, even if it's right at the, the top of the tree. Because when you do things like liver transplants, you get amazing surprises. Patients do well, and they've got a much better quality of life afterwards. People are happy. So I guess that's one of the things that I've learned about working in this area. A group that in the past has been easy to dismiss. but they're just as entitled to the same standard of care as anybody else.
Yeah, that's probably a really good sentiment for us to finish on tonight. I'd just like to thank you, Ted, and to thank you, Judy, for your input tonight. It's been really invaluable. It's taken me back to medical school with some of those diagrams.
Yeah, from Grey's Anatomy, yeah.
How connected the
I hope you didn't
brain.
try and read it like I did.
I just got cold shivers down my spine looking at those things. So I appreciate you bringing that back, and the importance of how the gut is so related to our health, and particularly the brain and everything like that. So it's a really important subject to discuss tonight. So I'd like to thank you for coming. I think we do have a slide about the participation survey. So I think there's the link in there. So there we go. There's the slide. If people can give some feedback on that, I'd like to thank everyone. I'd like to thank the Spider team for their hard work, and all the team at the Westvic PHN for organising these webinars, and look forward to seeing people again for the next one. So thank you very much.
Well, thanks for the invite.
Thanks, Judy.
Thank you.
Thank you very much, everyone. Bye-bye.
Thank you. Bye.
Thanks, Robert. Bye.